Thank you. Don't you want the video of him presenting?
No, thank you.
Oh, is that to go?
Thanks.
All right, hello, everybody. I was asked to speak on new procedures that were coming along as far as they pertain to, and to help with understanding for billing and billing purposes. So that, I also decided to put in information on all the other procedures that we do also, the cystoscopy. I think you've got a little background in it, but I think I'm going to go in a little bit more detail. And I have some visual aids here to help understand, and so hopefully if you have any questions as I go along, help. If it doesn't make sense or you don't want to hear it, just let me know. So this is urological procedures. So I'm going to start out with what I just said. And then, so the urinary system. Here I have my
Yay.
artist rendering right here.
Check that out. Awesome. Cool.
So, and of course, you hear these terms all the time. We'll hear both kidneys, the ureters, the bladder, and the urethra. These two always get confused. As far as like for dilating, the ureter and urethra. So, and here, the parts of the kidney, the renal pelvis, and the upper, middle, and lower pole. You'll hear the term ureteropelvic junction, or UPJ. That's just where the two come, it's just a positional thing here, where the stones could sit there, and they say it's in the UPJ. It's just between the pelvis and the ureter. That's all that means. And then the same down here, if you, the UVJ, ureterovesical junction, it's between the bladder and the ureter. And then way down here, I go into more detail with this later, the urethra, and then the prostate, which we do procedures on now, is just sitting right here, surrounding the urethra, and then as it swells, it pushes this shut, and then that's why you have trouble urinating. So those are the basics of it, and these are all little things that I'll give in more detail on. Okay, cystoscopy. Our basic procedure is the cysto-ureteroscopy, which is just a way to look into the bladder. You're basically just going in the urethra, examining the bladder, and this is the basic scope that we use. Parts are, this section goes into the urethra, of course. And then this section here gets connected. And this is the telescope that the doctor looks through, gives you the image. And so this is the basic cystoscope. And with that, you can examine the bladder. And you usually do that if there's bleeding. You can, causes could be, if it's not the stone, could be a little bladder tumor or just irritation, infection. So that's the basic.
Bob, is that the basic one that you do, like when you go to a doctor's office and they say you have blood in your urine?
Yeah, they'll just do a quick
That basic
look. And this scope here is a little bit bigger than usually they'll use in the doctor's office. That's because we can use anesthetic in our setting. Okay.
I'm in pain already.
It isn't that bad.
That's how we went.
I had it.
Okay, and then I was going to talk about the basic setup, the cysto pack for sterilizing everything. That's just a self-contained pack, and then keeps the area clean. And then we prep with so, and then we start the procedure.
Bob, are those flexible? So how does it?
No, this is not flexible.
So
I'll show you the flexible
Okay.
later. But this is just for
Just to get
looking into the bladder, that's all it'll do. And then once you're in the bladder, you can use a little item like this. This is just the open-ended catheter. I probably shouldn't put that on there. But the open-ended catheter will fit through here. So once the doctor's looking in the bladder, then he advances his catheter, and he can then put it up the ureter, and then through here he can inject dye, and then you can visualize the whole urinary system that way. Or if you want, you can go right up to a stone. If you can see my little stone there, you can inject some fluid in here and then push the stone back into the kidney. So we do that a lot because the stones tend to break up better in the kidney where they have expansion room. But you can also treat them there. And like I say, you can, so that's what the catheters are used for. Stone manipulation, injecting dye, and then the guide wires, which is this little tricky little hard to hold on to thing that I'm going to do it without this. But once the wire is in place, this gets really thin. Just imagine that it's curled in the kidney there. Oops. Then you take a stent, which comes with a wire, with a string on it, which could stick out the urethra here, and then they could tape it onto the, tape it on your abdomen here. So when it's time to take out, they just pull this wire, and it comes right out. Then you don't have to stick a scope back inside. So that's what that's for. And these come in different sizes, shapes, thicknesses. And
Bob, I don't understand how the stent is used.
how it's used?
Is that to pull out the wire or to pull out the stone?
No, the stent is put in there to keep drainage from the kidney to the bladder. Because if you have this stone here blocking the urine flow, that's what causes the pain. So then if you put a stent beyond it, then you get urine flowing from the kidney, because this is hollow. So you get urine flowing
So it
from
goes inside of that.
the kidney to the bladder, and then the stone is, its blocking potential is eliminated.
So when you pull that stent out, does it yank the stone out too?
Not necessarily,
Okay.
because for various reasons, it'll dilate this. The stones, once the stent is in place, the stones can just pass down alongside of it. So they help in the passage of stones also.
Okay.
So by putting this wire into the stent, and now you got to keep in mind that we're right here on the outside of the patient. So this wire will go up into the kidney, and then you take this this little device here, just another catheter, and then once the stent is up where you want it, then this basically just pushes it off the wire, and then it sits in place right there.
Okay.
And then, so this proportion of it will be sitting in the bladder, and then when it's time, then it'll go in. If it doesn't have a string on it, it'll go in and pull it out. And we have little grasping forceps that do that.
I'm still on. You had it done?
Here it is here. So this will fit into the this one. This fits through here into the bladder, and then a little grabber, and then you just grab the end. And then you pull it.
Torture chamber.
It does.
Torture devices.
It is.
Gonna be a masochist to be a urologist.
Okay, now, so that's the stent insertion. And then of course,
How stem is, it's there.
sorry,
Stem, how it stays your.
how does it stay there? With these little curls on the end.
It stops it from.
It'll keep it, yeah, it'll hold it. Yeah, it'll just keep it from pulling out.
falling
I
out.
know you said you had different sizes. How do they determine what size a patient needs? Do you
You-
just go in with the
You
one
have
and
to,
see?
yeah, you have, well, from the x-ray, you can estimate. Some people will go, they'll ask you how tall you are.
Okay.
But I don't find that a very accurate way to do it. You have to look at the x-ray and then kind of measure out.
Okay. I know sometimes you'll start off with one and then they'll switch to another.
Correct. Yeah, because a lot of times they'll say, oh, how tall are you? Oh, you're 5'4". So they say, well, give me a 22 centimeter. And then when they put it in, it's sitting right here.
Mm-hmm.
It didn't go all the way up, so then they'll have to take that out and put in a longer length so that it sits up here on the top.
Okay.
And it has to sit here and it has to sit here. And if this is too short, then it'll pull up inside here, and then you won't be able to get it with just a regular cystoscope. You'll have to get it with the ureteroscope,
Mhm.
which we can do now.
Mhm.
But back in the old days, we didn't have them, and that created a big problem.
Okay. And the guide wire is what keeps it straight to get it all the way up there.
Correct.
And then when you pull the guide wire out, it curls up.
Correct. Yeah, as soon as you pull it out, it curls, and it should be in position. Usually use x-ray to make sure that it's sitting in there in the proper way. Okay. And then once the stent is in place, then we're ready to go shock. Whether it's, whether we were successful moving the stone, or we do a retrograde and we find it somewhere. Because not all stones will show up on x-ray. So you do a retrograde, and then you can find the stone down here, and then you know that that's where you have to shock.
So if the stone is not visualized, do you guys still continue with the procedure
Oh, sure.
based on where it was previous?
Well, we keep the catheter in, and then while we're shocking, we inject dye to make sure that we're hitting this spot.
Even if you guys don't visualize the stone?
Oh, we'll visualize it with the
You have to
retrograde.
visualize it.
Yes. The CT scan says it was here, so that's where we look, and then once we see it, then we'll start shocking. If it's not there, then those are the instances where we cancel,
Okay.
so. All right, let's see what's next.
Well,
Like
how
we're
often
doing
does that
sometimes
stone
twice
move
or
around
so.
or bounce
I'm
around
sorry?
during
Before and
treatment?
after, why we do x-rays?
Why do we do x-rays?
Twice, sometimes.
Sometimes afterwards?
Yeah.
Some doctors like to make sure that the stent is in good position, and then if we don't do a retrograde, then he wants them, and then in our old bathtub, it's hard, the x-ray isn't as, it's 30 years old, so it's a little hard to see stones sometimes. So he will look at where the stent is at, and then he'll be able to judge once we get into the tub that the stone is just right off the curl of the stent. So to help visualize before we start shocking.
You can visualize the stone through fluoroscopy too, as you're up there.
Most of them, yeah. But like I was saying, some don't show up on x-ray, and that's when you have to inject dye. But the calcium ones are the ones that show up really nice, and those are the harder ones to break too. But, okay.
He didn't hear you, man.
But
You have a question back here. Beth.
Yes, sorry.
So how often does the stone bounce around during treatment, and how do you keep track of it as it's moving?
As we're shocking, if it's right here in the ureter and we're shocking that, no problem, it'll just stay there. And it'll gradually just kind of spread, and then you can tell that it's finished. But if you push the stone up here into the kidney, and now the patient is kind of like, just kind of like laying reclined and tilted a little bit. So the stone, once you start shocking it, it'll tend to roll down here. And so you start shocking it and keep an eye on it. Every once in a while you watch it, and then as it rolls down, it'll eventually stop, and then you just continue getting right there. So you have to watch it and follow it.
Do
And
you
when
guys
it's at
move
the
where you're
bottom, just-
shocking?
Yeah.
A little bit.
Constantly. Yeah, because that's why X-ray is used quite a lot, because you want to make sure you're hitting the stone all the time. Patient coughs or something, then you gotta,
Remove.
that'll make it move. So you really have to be monitoring at all times. But, you know, the X-ray's not on all the time, it's just like a quick look, maybe a couple of seconds, and shut it off, take a look, shut off. So. Okay, now the rigid ureteroscope. We have new ones in the center now. This is one of our old ones. This is very old and ancient, but it works the purpose. And when I put the urethra on here, I kind of forgot that I was going to go up with a rigid ureteroscope. So actually this will go here, and the rigid ureteroscope will probably get about that far up into the ureter. That's about as far as you can go with it. So, so it's limited in what you can do, and mostly you go after stones that are in the lower third of, or lower 2/3 of the ureter here. Anything higher than that, then you switch over to the flexible scope. And this is a little bit dramatic, because as you can see, there's a little curve to the ureter here. But they call this semi-rigid because it does bend a little bit. And then when you put this up, it's going to straighten out the ureter a little bit too.
Can you have puncture?
Oh
I was just gonna ask that.
Yeah, you really have to be careful. So what they do to start out is they put a wire up there, and then the wire, then they'll just follow the wire up, and then very carefully so that they don't go through the wall of the ureter. If you go through the wall, it's not an irreparable damage. You put in a stent and then you're done, and then it'll heal itself. But
Does it leak urine through your body?
no, it won't unless there's like a lot of pressure. Like if you punctured up here and the urine was stopped here, it's going to squirt out like a balloon puncture. But if there's if there's no stone obstructing, then there's no pressure to make it come out. And let's see, give you an idea what. And these are our, well, this isn't our camera, this is a demo camera. This will give you an idea of what the doctors look at.
And can you
Can
have
you
a-
check the PC?
Can you guys see?
I'll put it on a bullet right in the book. Just need to put it on. All right, yeah, let's see.
There it is. Okay, so you have the ureteroscope and you have, take your home video here.
Hi, guys.
Okay. So
Karen
we're
here.
all dialed in, we're here. And you add a little bit of light. Oh yeah, this one doesn't fit very well. But then, with a little bit of light, grab this for a second, then you got a little view
Oh,
of something here.
Now, is this machine attached to our machine, or is this a separate, like, camera or monitor? This monitor here, is it attached to our, like, litho machine?
We have, yeah, we have much better equipment on our, in our system room.
Okay.
You know, that all of this stuff was brand new, the ureteroscopes, the cameras, and the light source. But this is just kind of a demo machine. The stuff that we actually use is much better. And this scope is, this is one of the reasons why they never did ureteroscopy. Because the image is very, but you can start to see letters there. And then you can see how, you really have to know where you're going if you're gonna follow a wire up. Every little movement is magnified too. So through here you can pass wires, you can inject dye, so you can do a retrograde without having to put a catheter in. So once this is up in here, you can inject dye, and then see if everything is cleared out. So.
It has to be pretty coordinated. They're looking at the screen and then working on the machine at the
Yeah.
same time.
That's where the video
Yeah,
games
they're
come in.
pretty,
They had to be good video for you.
they're pretty good at it.
You know how to work the joystick.
And then there's more hanging, there's also irrigation hanging off of this thing. So it gets to be kind of a trick, balancing everything. And then when you start passing baskets,
I got a question, on the IVP, do you guys inject it through that? Or how do you inject the IVP? Would it be through either scopes?
it could be, yeah. Like I was saying,
So IVP is like a dye, right?
It is
Another
dye.
form of a dye?
right. So you get, if you're not going up the ureter with a ureteroscope, then you just put the catheter in and inject the dye.
Can they do it through the ureteroscope
Yes,
too?
yeah. As long as this is already in the ureter, then
Mhm.
you're ready to go, you can just inject it through one of these ports.
Why do they do IVP and other, or different types of contrast, I guess, or different dyes? How do they choose that? Is it on the preference of the doctor?
Do they charge different types of dye?
We have different codes,
Oh,
so,
well, one is a very basic, cheap dye. Well, it's not that cheap, but it's but it tends to cause more allergic reactions. And then we have some that are a lot more expensive, and when you inject those, they don't cause an allergic reaction. Or if you have a sensitivity to dye, that's what we
what
use.
causes the doctor to do an IVP?
Can't see a stone.
Okay, and like we said, we did retrograde and we couldn't see it either, so they decided to do an IVP, or is it like one or the other?
What's the difference between?
Well, an actual IVP means intravenous intravenous pyelogram. So if you're saying, the actual IVP is shooting it into your vein,
Okay,
and that could cause some allergic reactions. So then we use that special dye
okay.
if we need to. But, oh yeah, that's right, because if we can't see the stone and we didn't put a catheter in, we got into the tub and we can't find anything, we're like, oh, what do we do now? So the anesthesiologist already has an IV started. He'll just put the dye through the IV,
Okay,
and then it'll come through the bloodstream and then collecting here, and then you'll start seeing an outline of the kidney.
how long does it take for it to go through the bloodstream?
About 10 minutes. Well, till you can start seeing it. So you inject it, and then you have to wait a while, and then it'll collect here slowly, and then maybe 20 minutes later, you start seeing it come down the ureter, and then it'll come out. It collects on both sides too. So that's, yeah, I guess that would be technically the IVP.
Okay.
What is the ureteral dilation?
He's getting there.
Ureteral dilation? You're right, I forgot about that.
It's on this screen, so that's right.
Okay.
More devices.
Yes, that's the
They
word.
sure, they do. Yeah, they want to show the question. out there. There's a lot of weird stuff that we're seeing.
Yeah.
This will give you the queasies, I guess.
Yeah.
Yeah.
that
So
one
the- Well, the reason why you have to dilate is because you gotta,
It's just went out.
oh,
I just gotta touch it.
the reason is you gotta get this scope in, and I don't know if you can see, but if you can't get it in the urethra, then we have these type of dilators, and they come in different sizes. They start out with a small, and then you gradually,
So is that the sound?
the sound.
So you just, how does it make the sound? Do you tap it or something?
No, back in the old days, you want some real history? Back in the old days, this was before my time, before cystoscopes or anything like that, they used to diagnose kidney stones by putting this into the bladder and then wiggling it around. If they heard a tap on the stone, that's how they diagnosed the stone, because it made a sound. But, so then they just kept the name. And so this will dilate the urethra, so you can get the scope in. And
Okay.
then later I'll show you the dilators that dilate the ureter.
I got a question. Would you ever have to dilate the urethra and the ureter?
Sure.
I've never really seen them two together. It's usually one or the other.
Yeah. Well, this is the most common. You'll get strictures for various reasons. And now when the scopes are so small these days that they pretty much fit right up the ureter here. You don't have to dilate all that much. Some people, they'll dilate so that they can pull a bigger stone out of there. Because this doesn't show it, but this narrows as it comes down. The narrowest part is right here. So that's why the stones always get stuck. They're traveling down here, boom, that's as far as it's gonna go, being that size. So,
Nancy's got a question.
yes.
How long does it take to break up a stone? So is it broken up at the procedure, or does it continue to break even afterward?
No. The shockwave usually takes about 20-25 minutes, depending on the tub. If you put them in the tubs, 20-25 minutes. On the table, it tends to go slower. They like to go slower. It takes about 35 minutes.
And does that break them up?
Yeah. Yeah, it should pulverize it totally so that it'll just pass spontaneously in like little pieces. And then if you use a holmium laser, you go up and get it with a holmium laser, that'll take, depending on the size, it could take 5 minutes, depending on the doctor also, could take you an hour. Because you got to break it up and then you got to fish all the little chunks out, which I'll show you that. So, okay.
What's good about it?
These are the little baskets that you can put through the ureteroscope.
That's a basket.
They don't look like baskets.
It is.
Where's the basket at?
I thought it was
Now you can see
See
it.
the little loops to
Oh.
We
We
charge
charge
Oh, Lord.
So what you do is you go up beyond the stone, open this up, and as you pull it down,
Oh, yeah.
it'll put the stone right inside, and then you just continue to pull it out.
Does the stone ever like fall out?
Oh, yeah.
Is it difficult?
Yeah.
So are you ready to do the procedure?
No.
I want to know about this pumping system. I've been seeing that a lot lately.
Oh, good call. Okay. So that's the basket, and you can use this, and they do use these to get up with the flexible ureteroscope to get up into the kidney, and then they can pull it all the way down. And with the flexible, that's really a trick to get all those pieces out. I suggest shockwaves. If they're in the ureter, definitely ureteroscopy is very good. Okay.
Next one.
So if there is one stone in there, then you pull it out easily, that's good. I'm not totally against flexible ureteroscopy, but it could take, I've been in a case that lasted 3 hours, trying to get, because you laser it and then it scatters all over and then you spend hours just pulling out little tiny pieces.
Why not wait for
Why don't
it
they just
to?
let them pass them?
Yeah.
Perfectionist.
I'm done with that.
Okay,
Are we up next one?
cover everything. Oh, I might as well do the pumping devices here. Usually you have to put irrigation on one of these ports here. And, because once you're in the ureter, it kind of collapses on you. So if you put some water pressure in there, it'll expand the ureter, you can see where you're at. And so the different ways to do that is, what I normally do is hook up an IV bag, hook it to this, and then put a pressure bag on that, which will squirt the water in. There are some guys, this is called a Pathfinder. So what this does, instead of the pressure bag, they hook this up to it. They just, whenever they need a little bit of water, they just put it, and they just pump
And
it.
that's attached to those the scope?
It's attached to the scope. And then through the scope, you will, let's shut it off here. So through the scope, he'll just continue whenever he needs it, just adding a little bit of water pressure so you can see.
Is that something new that you guys are using more now, this pumping
The
system?
pumping system,
I'm seeing it a lot more lately than before.
up north, we don't do it.
Well, maybe it's west, I'm thinking.
West uses this.
Hmm.
Because I think Dr. Leyland likes this. And in New Mexico, they use the Pathfinder. So they like to do it manually. Like I say, up north, we just hook up a pressure bag and it's just constant pressure. They just regulate it with a little valve.
So no extra supplies with that?
No.
Is that why we don't ever see that like
Right.
marked or anything?
So now, this will connect in line to the, where does it go? Well, this connects into the water bag. And then they'll have a constant flow of water. And then this will connect to the ureteroscope. And just like the Pathfinder, every time they want to give a little bit of pressure to where they're looking, and they just, another manual technique. But this is the single action pumping device.
Okay.
Sorry? Why do you need water? Because everything here is filled with urine or water. So you're in order